Thank, thank you, David, for this opportunity. Cancer is a major public health burden, as we have heard yesterday and today, various speakers speaking. More than 1 million new cancers diagnosed annually, and about 700,000 dying every year. And 70% who are diagnosed die within 1 year of diagnosis. And sadly, a large majority of them die in the most productive period of their life. Less than a third survive more than 5 years. And the economic impact on the economy due to cancer is about 12 billion US dollars every year. India is a low middle income country, a per capita income of more than $1,000. But it's worth remembering that more than 25% earn less than 40 cents a day. It was mentioned that the GDP on healthcare is quite low, especially on public health, which is one of the lowest in the world at around 1%. The budgetary allocation for health is about 2% of the healthcare budget, of the central budget, and the public health expenditure on cancer is less than 10 US dollars per person. What are the features of health care in India? It's a high level of privatization. Most urban and rural populations seek care from rapidly growing and unregulated public sector. At the time of independence, private sector accounted for 8% of all hospitals. In 2011, it's a major player. 93% of hospitals, 80% of outpatient visits, and 50% of inpatient admissions. And private sector accounts for 79% of healthcare expenditure. What are the features of private healthcare? It's expensive. Most of it is unregulated. The absence of quality standards. They don't follow cost-effective, evidence-based protocols. And very often we find unnecessary investigations and treatment, especially in advanced stages of disease and in palliative settings. And there is lack of transparency regarding costs and outcomes. Cancer care is expensive. Drugs are perhaps the most important component, and the prices are increasing. In addition, transportation, food, cost of accommodation, and lost wages add to the burden. And if you look at it more closely, most of the costs are incurred on treatment of advanced and metastatic cancers. We don't have reliable data from in India, but from the United States, only 5% is spent on curative treatment. The rest, 95%, is for treatment of advanced cancers. And the high costs of hospital-based end-of-life care. And the fashion of the day is more and more imaging, and that is adding to the burden. Cancer also has the highest out-of-pocket expenses. Nearly 3/4 of health expenditure in the country is out of pocket. And it accounts for nearly 20% of rural households' total expenditure. More than 50% of Indian households borrow money or sell assets to finance inpatient cancer care. And the rural low-income people are the most vulnerable and affected, and 50% of them are pushed to catastrophic poverty due to out-of-pocket expenses. Health insurance is something which is not widely available in the country. Only 50% of the population is covered by insurance. There are a few social insurance schemes that target the vulnerable population which have been in existence in the last decade or so. One is the Rashtriya Swasthya Bima Yojana. It's a flagship program of the Department of Labor of the Government of India. There are schemes in Andhra, in Karnataka, in Maharashtra, Kerala, and Tamil Nadu. But they provide solace to some extent, but do not cover the full financial burden of cancer. And none of them are addressed to address the complexity and cost of care. For example, the RSBY scheme of the Government of India, it provided 30,000 rupees, or equivalent to approximately $465 per family per year. And importantly, it does not cover outpatient care, it covers for only inpatient admissions. But the average cost of investigations and treatment for cancer in a government hospital is around $970. See where we are. The delivery of cancer care in India, as was mentioned, is mostly through the regional cancer centers. There are 28 of them, through medical college hospitals. Some activity happens through the district hospitals and through private cancer centers. As per the latest figures available, there are only 357 cancer treatment centers with radiation therapy facilities, which, as Dr. Pramesh pointed out, it is woefully inadequate for the large number of patients we have. And most of them are in urban centers. 40% of them are situated in the top 6 cities. Less than a third of them are in the public health sector. And as was mentioned by both the speakers, there's a gross regional imbalance in their distribution, most of them in the south and to the west. The north, the central part, the east and the northeast are awfully inadequate of these facilities. And to add to the problem, most of these centers are not comprehensive, which means that they have only radiotherapy facilities, or they may have a surgeon. There are no surgical oncology or medical oncology facilities under one roof. And whatever facilities they are poorly maintained, and many of them lack many of the essential requirements to treat cancer properly. In addition, there are staff shortages, patient overload, resulting in long waiting times, resulting ultimately in delayed diagnosis and treatment. Again, a repeat of what was mentioned. Acute shortage of trained manpower, and who gets trained, and most of the training happen in government hospitals, and the students study with subsidized fees. After coming out, majority of them take up positions in private hospitals in urban areas. What adds to the late stage of presentation and increased cost of treatment are illiteracy, lack of awareness, myths and stigma, misconceptions regarding prognosis and outcome, lack of screening program, and very importantly, inappropriate initial treatment. There is no organized cancer screening program anywhere in the country. There are a few programs which are run as an epidemiological research basis, but opportunistic screening is available in major centers, in major urban centers. Why all this happens is because there is a lack of political commitment. And whatever scarce resources are there, we find that there is inefficient or underutilization of these funds. For example, in the last 5-year plan, every major cancer center was allotted about $1 million worth of money for infrastructure development. But out of 65 institutions which were eligible for this, only 12 could utilize this amount of money. The rest of the money was wasted. There is a total disconnect between planning and implementation of programs. So what needs to be done? The most important thing is cancer should be made a public health priority, and that has to be a political decision. A national policy to ensure healthcare access to all. The public expenditure on healthcare should increase from the present 1% of GDP to at least 5% over the next 5 years. Strengthen the existing public healthcare system with improved infrastructure and additional manpower. And additional revenue for this could be raised by raising the taxes on tobacco and alcohol The WHO recommends at least 70% of taxes for tobacco. Most of the states the tax rate for tobacco is about 20 to 25%. Just a couple of states which have more than 50% of taxes for tobacco. And another important thing which needs to be done is regulation of private healthcare providers. We need to create more comprehensive cancer centers, especially in regions which lack it, and upgrade existing ones by improving their infrastructure and by providing comprehensive care. Increase in training opportunities in all fields of oncology, not just doctors, nurses, physicists, technicians, and short-term training for general practitioners of oncology. And we should look at ways and means to retain the health personnel in the public health sector by incentives, adequate remuneration, career track progression, and supportive work environments. And a contentious issue, what needs to be looked at is some sort of obligation for those who graduate to work in a public institution for a couple of years. Providing free or subsidized health care is another major issue. There should be an easily accessible, cashless, comprehensive health insurance which adequately covers expenses related to diagnosis and treatment of cancer, including transportation and rent. And such a scheme should include the poor, the disadvantaged, the marginalized, children, women, and the elderly. This should be a major priority of the government. And there should be a decentralization of cancer care. At the moment, all what's happening is happening in the few tertiary cancer centers situated in urban centers. We have 640 districts, that means 640 district hospitals. And they could be used to some extent to share some of the burden of these tertiary centers, like creating awareness, diagnosis, management of patients who have completed treatment at the tertiary centers, administration of some form of simple chemotherapy, long-term follow-up, and palliation. Such steps would reduce the workload in the tertiary centers, which would thereby reduce treatment delays and improve compliance to diagnosis, treatment, and follow-up. Tobacco control and other measures of primary prevention, like giving up alcohol, hepatitis B vaccination, promoting physical activity, and healthy dietary habits are also very important in our broader goal of achieving equitable and affordable cancer care. Tobacco accounts for 40% of cancers in our country. About 1.5 million tobacco-related deaths and morbidity due to tobacco. And the total and indirect cause of tobacco-related disease exceeds the total expenditure on health, water supply, and sanitation in the country. As I mentioned, we need to increase taxes on tobacco, and we have excellent laws for tobacco control, and strict implementation of them should be done. We need low-cost, feasible, and screening programs which are acceptable for widespread adoption. We have now proven that we have simple, low-cost technologies for screening of cervix, breast, and oral cancer. The VIA for cervix, the clinical breast examination for breast, and the visual examination of the oral cavity for oral cancer. At the moment, most of these such screening programs are vertical programs. These programs should be offered through existing public healthcare delivery system if they are to achieve any long-term goals. And at the same time, there should be hassle-free, seamless referral system of diagnosed cancers to tertiary institutions. Again, what was mentioned, we need to actively take up techniques like hypofractionation in radiotherapy, like in the treatment of breast and head and neck cancers, two very common cancers in the country. Use of single fractions for palliation of advanced disease. These will reduce travel time, out-of-pocket expenses, and distress to patients and their caregivers. Medical imaging is emerging as a major contributor to costs. PET scans are becoming fashionable. Try to avoid them for long-term surveillance. Limit expensive imaging to situations in which there is strong evidence of benefit. Another area of gross expenditure is end-of-life care, hospital-based admissions and care. If you could manage the patients at home, on home-based palliative care, and home-based palliative care is actually quite established in different parts of the country, and avoid expensive drugs for palliation. Develop and implement evidence-based, cost-effective national protocols for diagnosis and treatment of common cancers. This is very, very important. And at the same time, develop guidelines to make decisions to offer free or subsidized treatment at government cancer centers based on economic grounds. Resources are scarce, so they should be spent very prudently. And things to think about are more use of oral metronomic chemotherapy, drug repositioning, as Dr. Pramesh was mentioning, and to look at low-cost machinery for delivering of radiotherapy. The Baba Atomic Research Center put in a lot of effort, and they have come out with the Babatron telecobalt machine. At the latest count, about more than 20 machines have been produced and are functioning satisfactorily in different cancer institutes in the country. Similarly, effort has been put into development of a linear accelerator, and 2 such machines have been developed and installed so far. These machines cost only less than half of what an imported machine would cost. Drug costs are the major burden of cancer expenses. One should think of using generic drugs more and more, especially through the government-funded insurance schemes. Should think of national network of pharmacies for distribution of drugs. And government should initiate mechanism for bulk purchase of patented drugs, which could bring down the cost of them somewhat. And we heard about other means of controlling the price the other day, like price discrimination, compulsory licensing. India has already given compulsory licensing to 2 drugs, and looking at public-private partnerships like the Gavi Alliance for vaccines. And as Dr. Pramesh elegantly put it, the National Cancer Grid, which was formed recently, has a mandate to look at all these aspects, especially the development of cost-effective guidelines, development of trained manpower in oncology, and collaborative research to find cost-effective solutions. So, to sum up, the way forward for equitable and affordable cancer care in India is to expand and improve the public health infrastructure, to address manpower shortages, and to deliver health care through a universal health cover package, to develop national cost-effective protocols for management of these cancers, and to regulate medical practice. Thank you for your kind attention.
Thank you very much. I think we've just seen 3 very elegant presentations there with some very rational solutions and ideas. Clearly a lot of thought has gone into this program. Are there questions from the floor? Thank you. Our resident questioner.
Thank you for the very insightful presentation. I have got 2 questions. I saw Dr. Pramesh's presentation, and what struck me was the dissimilarities between the 2 sister institutions. It seems that Tata Memorial has got about 1/10 of the trained personnel to handle the cancer cases. And of course, when our 3rd presenter said that a lot of the publicly trained physicians eventually filter out and go to the private. So besides offering incentives, is there any move to allow them to have, those who are in the public, to actually have private practice after office hours or something? Because we have that here. And of course, the charges that they can make up for the income during their private hours, and it's still less than what is being charged in the real private setting.
Short straw.
That's a great suggestion, and I wish it would work. Actually, Tata Memorial had this kind of a situation about a couple of decades back. It's about 15 years back now that we shifted back to a full-time system, and that happened purely because the system was abused. So what physicians who were attached to the Tata hospital were allowed to do was to spend 2 half-day sessions in other private hospitals and spend the rest of their week at the Tata. And what actually happened quite often was the reverse. They actually ended up spending 2 weekday halves. So it's again a question of how these, it's a great concept, and if it worked, it would work well. But unfortunately, the experiences we've had in several such institutions have not been very positive.
Thank you. And the next question is actually for our third presenter, because he actually mentioned about screening and making it, rather than a vertical program, try to expand it. And great examples are using BIA and clinical breast examination. But that will increase in a surplus of cancer cases who are newly diagnosed. So if we do it outside of the vertical setting, how then there must be a lot of resources required to channel people who are screen detected, where would they go, and things like that. So it must be something that is going to be quite resource intensive in the beginning, I guess.
Yeah, that is a real issue. The problem with vertical programs is the moment the program stops, the whole program comes to a shutdown. And we have seen that on several occasions in our country. So for things to be sustained, it has to be integrated into the existing health system. As you mentioned, there could be issues of a large number of cases being picked up, large number of pre-malignancies being picked up. So we need to sort of build up capacity at secondary and tertiary institutions to take care of these issues as well while we promote the screening. In Kerala, the state where I come from, we have just launched a statewide screening program for 3 cancers: oral, breast, and cervix. So this is one of my apprehensions. What would happen to the number of cancers which are picked up, and more so to the pre-cancers which are going to be identified?
I'll just add on to that. I think that's a great question, that overdiagnosis is a definite problem with most screening programs. And I suspect part of the high incidence in the West could partly be explained by overdiagnosis, especially in prostate and maybe even in breast cancer. But if you look at the technologies that have been used here, these are clinical breast examination in breast, VIA in cervix, and visual examination of the oral cavity. It's highly unlikely that you're actually likely to pick up these occult, non-likely to be lethal cancers by these kind of methods. And I would very strongly suggest not to go ahead with things like PSA screening for prostate, or even for that matter, colorectal screening with fecal occult blood, because in India it would be a nightmare because of the helminthing infections you have, which are so prevalent. So if you use the right tools, I think screening would actually save lives.
It will save lives. It's just that probably you are still going to see a big surge, and that's going to be...
There's unlikely to be any screening tool without some bit of overdiagnosis, but I think if you can still achieve saving of lives and not have too much of a burden with overdiagnosis, I think it's still money well spent.
And this is also where you probably need to really look at universal health coverage, because what do you do with the cases you're finding? As we had a talk yesterday which illustrated that very nicely. If you're referring patients to a private practice and they cannot afford follow-up, what's the point? So, yeah.
Right, so my
yes.
comment was kind of a follow-up on that. So it's not really screening that's going to save lives, it's treatment that's going to save lives. And I think the point that Nirmala brought up was that linkage from screening to treatment is going to be one of the biggest challenges in many countries in this region, but certainly in India. Because there's some systems where it's already very well set up, like in the clinical trial from Tata. But when taking that nationwide, that linkage is going to be very difficult.
I'd agree. The only thing that we like to emphasize here is that you're not actually increasing grossly the number of patients you are likely to treat. And so if you have 72,000 people getting cervical cancer every year, it's likely to become 100,000 with screening. But nevertheless, you're treating 72,000 cervical cancers, with most of them being advanced, and on the other hand, you have 100,000 being diagnosed, which most of them will hopefully be early. And it's just a redistribution of resources that you'd require rather than actually need more resources. We definitely need more resources. Let's not get away from that fact. We need more public comprehensive cancer centers, but it's actually going to be a redistribution rather than an exponential increase in the need for... Do
we have any more questions? I have one comment. I always find it very striking when we see the cancer incidence figures from India and other countries which are very low. And the question that always comes to my mind is whether these numbers are real because of the lack of coverage of the registry data. So to me, really, cancer registries are right at the front end of what you need to be installing here. When you have a full comprehensive idea of your burden, then you know what you need to plan. Do you have any thoughts about how you're going to move towards 100% cancer registry?
I think 100% is
small.
We are close to 7% now, so
exactly.
100% is a really long way off. But some of it is artifactual, and I think I mentioned that in my presentation. Part of the so-called low incidence is probably underreporting, and this is more to do with diseases like lung cancer being diagnosed as tuberculosis, and not that a lung cancer is diagnosed but is not reported. It's misdiagnosis that's the cause rather than underreporting. But actually we have a very strong base in one of the rural areas of Maharashtra, Barshi, where we've established a hospital for over 30 years. And we've had a presence from the Tata Memorial Center at Barshi for 30 years, and we've been running the registry. And that's extremely robust evidence, and that has the lowest incidence of cancer across the country. It's 45 per 100,000.
Just a comment related to that. So looking at incidence in, sorry, do you want to go first?
Okay.
Go on.
You know, I looked at the trends of cancer in Australia, in the UK, in the US, Canada, etc. over the last 100 years. And if you actually see, if you take the million death study, death distribution, it is like what it was in the UK 100 years ago. I think it is a process of epidemiological evolution. Cancer deaths in the UK was very low 100 years ago. That time tuberculosis, typhoid were the leading killers. It was true in New York, it was true in Australia. And today, all that is gone and it is all replaced by cancer. And that's and in Japan, if you see the trends, it is somewhere in between. So post-war, the Japanese TB came down, lung infections came down, and cancer has overtaken. So we are in that transition. We are in cancer. We are maybe 100 years behind what it is in the development. It's not that it is being underreported. I don't think that because most cancers kill people, and if you look at the million death study, there's so much evidence that the numbers are almost similar. The mortality estimated for India in million death study is very similar to what it is in global cancer. So there is no underreporting. What is underreported, I think, is the urban-rural differences. Because the registries assume that if you've lived in Mumbai for 1 year, you are a resident of Mumbai. Maybe he came to Mumbai to take treatment there, and so there could be misclassification. But
I was going to say that we have some indirect evidence of under-registration, under-reporting from immigrants to the UK. So Indians, Pakistanis, Bangladeshis who moved to the UK have a high incidence of some cancers even than the native population in the UK. So you can't be explained by kind of risk factors. It must be that they had an increased risk already before they migrated. And that's been picked up by the better registration in diagnostic facilities in the UK. So I agree with Dr. Mohandas, there may not be the major reason for the difference, but I think there is definitely an element of underreporting.
One of the ways to circumvent this underreporting, if at all there is any, is like in India for example, some of the infectious diseases is notifiable. I mean, you have to report it if you get it. It doesn't matter where you get it. For example, in Tamil Nadu, if you were diagnosed with dengue, for example, you had to report it, irrespective of, and if you didn't report it, it was actually punishable by law. Now, you know, making cancer reportable is probably one thing that could help. And in Tamil Nadu, the government has actually sent out a circular saying that all hospitals that see cancer need to give the local regional cancer center a list at the end of the month as to the, you know, who the people that you've seen, and you know, not their identifiers, but which city they come from or which village they come from. And that's now, you know, all the circulars gone about, and they're trying to get this data together. The other thing that might help is if, you know, all Indians are given a number. And, you know, if the process is ongoing, actually. So it'll be interesting. In fact, I suggested a long time ago that, you know, say we're seeing, I don't know, 25 or 50, 25, 30 lakhs new patients per annum. And if the centers that actually see these patients are enabled, so instead of, you know, a government going around from house to house, the fellow who's, you know, if you come to your hospital, you make sure he has this number. Either he already has it, or you're able to give him this number. And then that number is then, you know, directed to death or any kind of, you know, thing that the government gives. And the government tried this out in the Aadhaar. I'm not sure how much they've actually penetrated, but it's been, you know, quite good. So I think that's another successful thing that is going to happen as it is. So there's some hope.
Actually, following from that, coming from Malaysia, I got two stories to tell for both of the comments. So let me start with the good one, the second one of having an identification number. So we do have one, and that has been very useful in getting our mortality tracked, and it is really helpful. But on the other side, talking about mandatory reporting of cancer, we have been fighting for a very long time. And recently, about 3 weeks ago, the National Cancer Institute from US came over and we had a nice cancer control meeting. And one of the things that we again said is, why don't we make it compulsory? But then one of the things that one of our colleagues from the Ministry of Health had actually rightfully pointed out is that, of course, we have mandatory reporting of 36 infectious diseases, and it's a wonderful system. It works very well, especially in dengue and all this stuff. But for cancer, it's slightly more complex because it's not a one-day diagnosis. It's not a 2-day diagnosis. So, and then we have this problem of, yes, the ministers can try to make it happen, but who is going to do the reporting? So it's like we have no manpower. But of course, we all would love to see it. And when they actually explained that to us, we thought that maybe it makes sense. You know, sometimes we say we want it, but probably it's more complex than that. That means it entails with a lot of resources being planned before the minister comes up and say you must do mandatory reporting.
Yeah, I'd just like to add on that. You know how the cancer registries work, because we don't have any unique number, and the patients go around shopping. You know, if somebody comes to Mumbai, he goes to 4 hospitals, and if doctors were to report, there would be 4 cases for every real case in the city. So we actually look at name, surname, father's name, mother's name. Full details is actually provided. Without that, they are not enrolled into the... And there is a whole lot of people who sit and eliminate based on all these things. So it's a long, lengthy process. And it is a very dangerous situation because, you know, a lot of identity is revealed. Some of the cancers, you know, are HIV related. There are a whole lot of issues. The government just doesn't want to make it mandatory for that one reason, that it is, you know, one thing, it may overestimate the burden because of duplication, and second is that there are still taboo is there on cancer, and there are many private details that will be revealed.
Do we have any more questions? No? Okay, well, I think I'll bring this session to a close. I'd like to thank our speakers. Been fantastic presentations this morning, really a lot of food for thought. I'd like to thank you all for coming to Kuala Lumpur. I think it's been an amazing conference. and I hope to see you all again next year, somewhere in the region. So goodbye. See you.